Welcome back to the Radonc Smart Review GYN Cancer Series. I'll be your examiner today. We're jumping right into a high-intensity, case-based review structured just like a mock oral board exam. Our focus will be on some high-yield GYN cases, specifically definitive management for locally advanced cervical cancer, and then risk-stratified adjuvant therapy for endometrial cancer.
Okay, I understand the format. I'll aim for structured, confident answers, really focusing on the clinical decision-making and the rationale behind it.
Excellent. And for you, the listener, this is your chance to pause after I ask the question, try to formulate your full answer out loud, and then you can compare it against the model answer from our examinee. We're looking for structure, depth, and most importantly, the why.
Ready when you are, let's start.
All right, let's begin. Case number 1. Your patient is a 45-year-old female. She presents with postcoital spotting. On clinical exam, you find a 5-centimeter cervical mass. And crucially, she has a firm nodular right perimetrium, but that nodularity does not extend to the pelvic sidewall. Biopsy confirms invasive squamous cell carcinoma. A PET CT is negative for nodal or distant metastases. First, state the FIGO 2018 stage, and then detail the comprehensive treatment recommendation. I want to hear the rationale for all the modalities you're going to use.
Okay, I'll answer that in a few parts. First, the stage, then the standard of care, and then the comprehensive plan. So for the diagnosis and stage. The presence of a mass that's larger than 4 centimeters, combined with that clinical perimetrial involvement, the firm nodular right perimetrium you mentioned, that puts her at FIGO stage 2B. And we also note the clinically negative nodes from the PET. For the standard of care for FIGO stage 1, B2 through stage 4A cervical cancer, it is definitive concurrent chemoradiation followed by an image-guided brachytherapy boost. Now for the comprehensive plan outline. There are really 4 essential components here. First, we have external beam radiation therapy, or EBRT. We would treat the whole pelvis, so that's the uterus, cervix, perimetria, and regional nodes, to a dose of 45 gray and 25 fractions. I'd use IMRT or VMAT with daily image guidance to really respect those organ at risk constraints. Second is the concurrent chemotherapy. This is absolutely critical based on the landmark randomized trials. We'd use weekly cisplatin at 40 milligrams per meter squared and would coordinate that closely with medical oncology.
And that dose is the standard, isn't it?
It is. It's the standard weekly radiosensitizing dose.
Okay, what's the third component?
Third is the brachytherapy boost. We do this using high dose rate, or HDR. After the EBRT is done, we deliver image-guided HDR brachytherapy. And our main dosimetric goal here is a cumulative equivalent dose in 2 gray fractions, or EQD2, of greater than 85 gray to the high-risk clinical target volume D90.
And why that specific number, 85 gray?
That dose is based on decades of data. There's a very clear correlation between achieving that high dose and getting superior local control.
Makes sense. And the fourth point?
The fourth point, and this is absolutely paramount, is overall treatment time. The entire course of radiation from day 1 of external beam through the last fraction of brachytherapy must be completed in 8 weeks or less.
That's a very complete answer. Let's focus on that last point you made, the overall treatment time. Why is that 8-week constraint so critical? What's the biological consequence if we let it slip to, say, 9 or 10 weeks?
That's a great question. The tight timeline is critical because of tumor repopulation kinetics. Cervical squamous cell carcinoma has a pretty fast doubling time. And once we start EBRT, the surviving tumor clonogens can actually accelerate their repopulation. So landmark studies have shown a demonstrable drop in local control, we're talking up to 1% or more per day, if that treatment extends beyond about 50 to 55 days. So extending the treatment is essentially letting the tumor regrow while you're trying to kill it. The brachytherapy component, which delivers that big definitive dose, is essential to counteract that accelerated repopulation and maintain those high local control rates.
Excellent. The radiobiology completely justifies the clinical urgency. Okay, now let's assume she has a partial but satisfactory response to her external beam. You're proceeding with a standard tandem and ovoid brachytherapy boost. I need you to walk me through the entire step-by-step procedure for the insertion. This is where precision is key. Detail the setup, every physical step, the rationale for the appliance placement, and all your safety checks.
Okay, so the procedure is done under anesthesia with the patient in the dorsal lithotomy position and, of course, with strict sterile technique. I'll outline it in about 8 sequential steps. First is the setup and the exam under anesthesia, or EUA. I place a Foley catheter, and then I perform a speculum, bimanual, and rectovaginal exam. The purpose here is to assess the final position of the uterus, tumor regression, and just to make sure no new fixation has developed. We record all the residual tumor dimensions.
So you're reassessing the anatomy right before you place the applicator.
Exactly. The second step is uterine sounding. I gently sound the uterus to determine its length and its version. Then I immediately use that measurement to set the tandem flange. Crucially, the flange is set about 5 millimeters shorter than the sounded depth. The rationale is purely safety. It helps prevent perforating the uterine fundus during insertion.
A critical safety step. Go on.
Third is cervical dilation. If it's necessary, I perform very cautious dilation of the cervical canal, just enough to allow for an atraumatic insertion of the tandem. Fourth, tandem placement. I select the right tandem curve straight, medium, or steep, and insert it carefully up to the fundus, making sure to respect the natural angle of the uterus, whether it's anteverted or retroverted.
And after the tandem is in?
Fifth is ovoid placement. Here, I select the largest possible ovoids that can fit comfortably, and I seat them symmetrically in the vaginal fornices.
Why the largest possible?
Because the dose from the ovoids falls off so rapidly with the inverse square law. A larger ovoid diameter gives you better lateral dose coverage to the perimetrial tissue, which is where the high-risk disease is.
Good. What's next?
Sixth is packing. This is meticulous. I perform vaginal packing with gauze, placing a lot of material anteriorly and posteriorly. This does two critical things. First, it displaces the bladder and rectum as far away as possible from the ovoids, and second, it stabilizes the entire applicator geometry. It can't move.
And you do a safety check at this point.
Yes. Seventh is the safety check. Before the patient even leaves the procedure room, I do a quick transabdominal ultrasound. This is an immediate check that confirms the tandem is in the uterus and we haven't perforated anything.
And the final step.
Eighth is imaging verification. We transfer the patient for a planning CT or an MRI. And on that scan, I have to confirm four things. Tandem is central, the flange is flush with the O's, ovoids are level and seated, and most importantly, the packing has effectively displaced the rectum and bladder. If anything is suboptimal, we have to adjust and re-image right away.
A superb and comprehensive procedural script. And here's a key examiner's teaching pearl for you listening. When you're discussing a brachytherapy procedure, you have to integrate the rationale for safety at every single step. Sounding shorter than the uterus, using the largest ovoids for lateral dose, meticulous packing. These are non-negotiable details. They signal you understand the procedure, the physics, and the safety goals. All right, let's complicate things. For her second brachytherapy insertion, you find that significant vaginal stenosis has developed since the external beam radiation. It's preventing you from placing the standard ovoids effectively. How do you adapt your applicator choice and plan to maintain that critical perimetrial dose coverage?
Okay, that's a tough but common scenario. The loss of that ovoid space because of stenosis is a serious dosimetric challenge because, like we just said, the ovoids provide that crucial lateral dose. So my adaptation would follow a clear hierarchy. First, I'd move down the applicator hierarchy. My first step would be to switch to a tandem and ring applicator. The ring is often a bit less bulky and can sometimes seat better than ovoids in a stenotic vault, so I'm trying to regain some of that lateral dose.
And if the ring doesn't fit or it's still inadequate?
If the ring is still not doing the job, I'd then have to use a tandem and cylinder. But, and this is the crucial part, I have to recognize the dosimetric consequence of that. A cylinder provides significantly less lateral dose to the perimetria. It's just a geometric fact. So after I get the imaging, if the high-risk CTBD90 is still below our target of 85 gray EQD2, I have to escalate the technique.
And what does that escalation look like?
The required escalation is a hybrid intracavitary interstitial approach. This means keeping the tandem but adding multiple lateral interstitial needles directly into the perimetrium. These needles are placed using a template to fully encompass the HRCTV and restore that needed dose coverage, all while still respecting OAR constraints.
Exactly. The key insight there is knowing you have to move to interstitial needles to guarantee coverage, even though it's more complex. You correctly identify that applicator progression. So another teaching pearl. Your applicator hierarchy ovoids, to ring to cylinder, and finally to interstitial, is not just a list. It represents a descending order of ability to deliver lateral perimetrial dose. If the tumor is still bulky, a cylinder is almost always inadequate, which demands that jump to interstitial needles to avoid a geometric miss. Let's pivot now to endometrial cancer, case 2. A 72-year-old female undergoes a total hysterectomy and bilateral salpingo-oophorectomy for a FIGO grade 2 endometrioid adenocarcinoma. Pathology shows 80% myometrial invasion, so T1B status. There's no LVSI, and she's pathologically N0. What is your adjuvant treatment recommendation, and what is the primary randomized evidence that supports this?
Okay, I'll answer that based on risk stratification and the trial data. First, the risk stratification. This patient is classified as high intermediate risk, or HIR. The criteria for HIR are met because she has two key features: deep myometrial invasion, that's the T1B status, and an age greater than 60 years. She's also grade 2. So my recommendation is adjuvant vaginal cuff brachytherapy, or VBT alone. We would not routinely recommend pelvic EBRT in this setting.
And the rationale.
Evidence. The primary site of recurrence for HIR patients is the vaginal cuff. So the decision to use VBT alone is really anchored in the results of the randomized PORT-EC2 trial. That trial directly compared pelvic radiation versus VBT alone for these high intermediate risk patients. And PORT-EC2 showed that VBT was statistically non-inferior to pelvic EBRT for overall survival, recurrence-free survival, and most importantly for vaginal control.
And what was the main takeaway from that trial regarding toxicity?
The main clinical benefit was the huge reduction in toxicity. Pelvic EBRT was associated with significantly higher rates of grade 2 or greater GI and GU toxicity compared to VBT alone. So VBT alone is the preferred standard. It maintains local control with a much, much better quality of life profile.
Excellent. You correctly identified the risk group, and you anchored your recommendation right in PORT-EC2. Perfect. So you proceed with VBT. Outline the complete procedural script for vaginal cylinder high-dose rate brachytherapy. I want you to emphasize the key dosimetric goals and how you manage late toxicity.
Okay. My VBT procedure involves 6 key steps, really focusing on geometry and dose. First, applicator selection. I do a pelvic exam to make sure the cuff is fully healed. Then I select the largest possible cylinder diameter that is comfortable for the patient.
And why the largest cylinder?
Using the largest cylinder ensures the shortest possible distance between the source and the vaginal mucosa. This leads to a more homogeneous dose and just ensures good contact all the way around. Second step is placement and documentation. I insert the lubricated cylinder flush with the vaginal apex right at the cuff suture line and verify it's centered. The position has to be documented precisely for planning. Third is simulation. For the first fraction, I always get a CT scan with the cylinder in place. This confirms it's straight, not tilted, and it lets us calculate the exact distances to the bladder and rectum before we treat.
Okay, and the prescription?
Fourth is the prescription and length. The standard prescription is 21 gray delivered in 3 weekly fractions. That dose is prescribed to 5 millimeters depth from the cylinder surface, and we typically treat the proximal 3 to 5 centimeters of the vagina. We always have to report the dose at both the surface and at that 5 millimeter depth.
Good. And what are your planning constraints?
Fifth is clanning. I make sure 2 critical physics goals are met. First, the 200% isodose line has to be contained entirely inside the cylinder. This prevents mucosal hotspots. Second, I verify acceptable bladder and rectal doses.
And final step, long-term management.
Sixth is delivery and follow-up, which is all about toxicity mitigation. After treatment, I counsel the patient on a comprehensive vaginal dilator program. This should start about 4 to 8 weeks after treatment, and they use it several times a week long-term. This is absolutely essential to prevent vaginal stenosis and maintain sexual function.
That detail on dilator counseling is key. It shows you're thinking about long-term patient outcomes. So another examiner is teaching Pearl. You must know the VBT prescription. 21 gray in 3 fractions to 5 millimeters depth, treating the proximal 3 to 5 centimeters. And that physics rule keep the 200% isodose line inside the applicator is a common board strap. And of course, failure to address long-term stenosis risk with a dilator program is a failure of comprehensive care. Let's revisit that HIR patient, 72 years old, grade 2, T1B. But this time the surgery was done at a community hospital and no lymphadenectomy was performed. Her nodal staging is unknown. How does this critical omission change your recommendation? Do we automatically escalate to external beam?
Yes. The lack of nodal staging, it completely changes the risk profile. So my structured response here would be, first, to acknowledge the risk change. Because this patient meets HIR criteria, deep invasion, advanced stage, the risk of occult pelvic nodal involvement is substantial. It's probably in the 10 to 15% range. We just can't treat only the vaginal cuff when the nodal status is unknown and these risk factors are present.
So what's the recommendation?
Escalation. VBT alone is insufficient here. It's inadequate treatment. I must escalate to include the pelvic lymphatic. So I would recommend pelvic EBRT to 45 gray, followed by a vaginal cuff brachytherapy boost.
Okay, but let me push back a bit. Why not just get a PET scan? Or perhaps do a salvage lymphadenectomy instead of radiating the entire pelvis? You might be overtreating a lot of patients who are truly node negative.
That's a very relevant clinical question. But imaging like PET-CT has a limited sensitivity for microscopic disease, which is our main concern in the adjuvant setting. And salvage surgery after the fact is not the standard of care for potential micrometastatic disease. The current consensus, based on patterns of failure in these unstaged high-risk groups, is that the risk of occult nodal failure outweighs the toxicity savings of VBT alone. When we don't have definitive surgical staging that proves she's N0, those other risk factors mandate treating the pelvic nodes.
That's the correct justification for the boards. The risk of occult disease is unacceptable in this setting. That's our next teaching pearl. In the adjuvant setting, when risk factors like age, T1B, grade 3, or LVSI are present, inadequate staging necessitates escalation. The guiding principle is this: when nodal status is unknown but suspected, you treat the nodes. All right, let's return to cervical cancer. Case 3, a 50-year-old stage 2B. She has just completed her 45 gray of chemoradiation. Post-EUA, you find a substantial 4.5 centimeter residual mass with persistent right parametrial disease fixed to the pelvic sidewall. It is geometrically obvious that a standard tandem novoid will not cover this. Justify, in dosimetric and anatomic terms, the required plan change.
Okay, this clinical picture is the textbook justification for moving to interstitial brachytherapy. So first, let's define the problem. It's an anatomic and a dosimetric failure. Because of that large residual tumor and the sidewall fixation, a purely intracavitary applicator just can't conform the high-dose region to the target. We cannot achieve our primary goal, the HRCTVD 90 greater than 85 gray EQD2, without violating hard OAR constraints for the rectum and bladder. It's a guaranteed geometric miss.
So what's the solution?
The solution is image-guided interstitial brachytherapy. I would perform a template-based implant, probably a perineal approach with a system like the SIAD or MUKIT.
And how does that solve the problem? What's the mechanism?
The interstitial technique lets us place multiple strategic needles directly into the residual tumor, the uterus, and that involved perimetrium. These needles act like multiple small radiation sources, and that allows us to really sculpt the high-dose isodose lines around the entire 4.5 centimeter target. We can restore the target coverage while simultaneously pulling that high-dose region away from the rectum and bladder.
Perfect. The justification always has to hinge on the inability to meet the tumor dose without exceeding OAR constraints using the standard device. Another teaching pearl: the physical limitation of the intracavitary device, that inverse square law and its lack of conformality, is what drives the need for interstitial. It becomes a dosimetric necessity when the anatomy is bad or the residual tumor is large, typically anything over 4 centimeters post-EBRT. Okay, you successfully performed the interstitial implant. The prescription is 6 gray times 5 fractions. The plan check comes back. The HRCT-VD90 is good, 6.1 gray per fraction. But the rectum D2CC is high at 7.0 gray per fraction. That's unacceptable. Walk me through your troubleshooting steps in order of priority.
Right. That's a hard stop. We cannot treat with that high rectal dose. My troubleshooting follows a very specific ladder. First, and this is the highest priority, a physical check of the geometry. I go straight to the planning CT. If there is even one needle that is visibly too close to, or worse, inside the rectal wall, the patient has to go back to the procedure room. Under image guidance, I'd try to gently reposition or retract that needle by just a few millimeters. That physical adjustment is the most powerful way to reduce the OAR dose.
So you fix the physical problem before touching the computer. What if the geometry looks okay?
Then step 2 is dosimetric optimization. I'll work with the physics team to reoptimize the dwell times. We would significantly reduce the dwell time in the needles closest to the rectum and then shift that dose weighting to needles that are more anterior or lateral. We're essentially sculpting the dose away from the rectum while trying to hold our tumor coverage.
And what if you've done both of those things and you still can't meet both goals?
That brings me to step 3, clinical compromise and prioritization. If we still can't meet both the ideal HRC-TV coverage and the rectal constraint, I must prioritize the OAR. I would strictly adhere to that rectal D2CC limit, the hard limit of about 75 gray EQD2 cumulative tolerance, even if it means accepting a small, clinically justified compromise in the HRC-TV coverage. A severe late rectal toxicity is irreversible. A minor dip in tumor coverage is a calculated risk.
That sequential safety-first approach is exactly right. Teaching Pearl: always prioritize safety. The troubleshooting order is: physical manipulation first fix the geometry, then dosimetric manipulation fix the dwell times. and only then clinical compromise. A dose violation to the bowel is a treatment failure no matter what dose you gave the tumor. Moving back to the endometrium. Case 4. A 60-year-old woman with a grade 3 endometrioid carcinoma. Final path shows T1b status with a positive pelvic node. That makes her stage 3 C1. She's planned for adjuvant chemoradiation. Describe your simulation setup, the EBRT volumes, and how you manage OAR constraints.
Okay, for stage 3 C1, we have to treat the pelvic nodal basins and the vaginal cuff. For the simulation setup, patient would be supine in an immobilization device like a body cradle. A comfortably full bladder is essential to push the small bowel up and out of the way. And, crucially, I'd get a contrast-enhanced CT for planning. You need IV contrast for accurate vessel-guided nodal contouring. We would treat with IMRT or VMAT with daily image guidance.
And the target volumes, what are you contouring?
I'd use the NRG Oncology and RTOG consensus atlases to define the CTV. This would include 4 main areas. 1, vaginal cuff and paravaginal tissues. 2, the obturator, internal iliac, external iliac, and common iliac nodal basins. 3, the common iliac chain needs to go up to L4, L5. And 4, given the high-risk features, grade 3 and positive nodes, I would also contour and include the presacral nodal basins.
And the prescription and constraints.
The prescription would be 45 to 50.4 gray in 1.8 to 2 grays per fraction. And the single most critical constraint in pelvic radiation is the small bowel. We rigorously trap the small bowel bag, aiming for the V45, the volume getting 45 gray, to be less than about 195 cubic centimeters. We also, of course, monitor the bladder, rectum, and femoral heads.
That emphasis on the small bowel V45 is absolutely the defining constraint. Teaching Pearl. For stage 3 C1, including the presacral nodes, is often debated, but it's highly recommended with grade 3 or other high-risk histology. And the need for a contrast CT and rigid adherence to that small bowel constraint are non-negotiable standards. Now contrast that with this case. A 66-year-old patient, stage 1, a uterine papillary serous carcinoma or UPSC. The disease is confined strictly to a polyp. No myometrial invasion, negative nodes, FIGO stage looks great. How does this aggressive histology change your adjuvant recommendation?
Right. This is a classic case where the histology completely overrides the low FIGO stage. First, the histology takes precedence. UPSC is a biologically aggressive, non-endometrioid tumor. It's more like a high-grade serous ovarian cancer. It has a very high risk of peritoneal and distant failure, even with minimal disease in the uterus. So that intrinsic aggression dictates the need for systemic therapy no matter what the stage says.
So what's the recommendation?
The primary driver of her outcome is systemic control, not local control. So I recommend adjuvant systemic chemotherapy, typically 6 cycles of carboplatin and paclitaxel.
And what's the role of radiation in this case?
I would still incorporate vaginal cuff brachytherapy to reduce her local vaginal recurrence risk. But omitting chemotherapy is not an option, even in stage 1A. Pelvic EBRT is not required, though, because the disease spreads hematogenously or transperitoneally, not typically through the pelvic nodes in this specific setting.
So you treat the biology of the disease, not just the stage. Examiner's Teaching Pearl. For aggressive, non-endometrioid histologies, UPSC, clear cell carcinosarcoma, your focus has to shift immediately to systemic control. Histology trumps stage. The default is chemo plus, at a minimum, local vaginal brachytherapy. Let's escalate again. Case 5, 68-year-old grade 3 endometrioid carcinoma. She has a positive para-aortic node confirmed at surgery. Stage 3 C2. What is the standard adjuvant approach for this level of advanced nodal disease?
Stage 3 C2 means disease is outside the pelvis. This mandates maximal combined modality therapy. One modality alone is just not enough. So the recommendation is systemic chemotherapy, again, 6 cycles of carboplatin and paclitaxel, plus extended field radiation therapy. This EBRT field has to cover both the pelvic and the periaortic nodal chains up to T12L1. We treat that to 45 to 50.4 grays, including the cuff, and this is followed by a vaginal cuff brachytherapy boost.
And the sequence of all that?
The current standard favors a sandwich approach. So a few cycles of chemo, then the radiation FRT plus VBT, and then completing the rest of the chemotherapy. This sequence gets the systemic agents in early while also definitively treating all the involved fields.
The need to cover that whole periaortic chain is essential. Teaching Pearl for you all. Stage 3C, 2 mandates, extended field radiation plus chemo. You must extend the field up to the renal vessels, and you have to integrate systemic therapy, often with that sandwich approach. Now, for the newest paradigm shift, you have a patient with a stage 1, a uterine serous carcinoma, which we just said is very high risk, but molecular profiling shows a POLE mutated tumor. How does this molecular finding influence your recommendation, potentially overriding that aggressive histology?
Right. The POLE molecular subtype is maybe the most favorable prognostic factor we have. It is a major de-escalation factor. So, as a prognostic factor, POLE ultramutated tumors have an extremely high mutation burden. This makes them highly visible to the immune system. Clinically, they are associated with an exceptionally low recurrence risk and excellent survival, often over 95%, regardless of any other adverse features.
So what do you do for the patient?
This molecular finding completely overrides the high-risk serous histology. I would de-escalate the treatment and recommend observation alone. Adjuvant chemo or radiation would be overtreatment. It would just expose her to unnecessary toxicity without providing any real benefit.
That's the modern, practice-changing answer. The data is clear. POLE mutated status is a ticket to observation, even for a histology that used to be terrifying. Examiners teaching Pearl. Molecular subtype is now fundamental. If a patient is POLE mutated, you must de-escalate aggressively. Conversely, P53 abnormal or mismatch repair deficient status usually leads to an escalation of therapy. Let's go back to the cervix. Case 6, a 6-centimeter cervical mass. The PET-CT shows bulky pelvic nodes and a biopsy-proven 2-centimeter common iliac node. No periortic disease is seen. What's the FIGO 2018 stage, and how does that common iliac node change your EBRT fields?
Okay, the location of that positive node is what drives the extent of the curative field. First, the stage. Biopsy-proven pelvic nodal involvement, including common iliacs, puts her at stage 3C1P. The reason the field changes is that a positive common iliac node, even if the periortics look negative on the scan, confers a really substantial risk of microscopic disease up the periortic chain. We have to treat that entire chain prophylactically.
So what's the recommendation? How do you change the field?
Standard pelvic fields that stop at L4, L5 are insufficient. I recommend prophylactic extended field radiation therapy. The superior border of the EBRT field must extend up to the T12 and L1 vertebral bodies. This ensures coverage of the entire periortic nodal chain up to the level of the renal vessels.
And the dose?
I deliver 45 grays to the extended field, with a simultaneous integrated boost to the grossly positive nodes, and then follow with brachytherapy to the cervix.
You explicitly stated the superior border. That's the necessary detail. Teaching Pearl. A positive common iliac node is the classic high-yield indication for extending the field superiorly in cervical cancer. Remember that critical landmark, T12L1. 2 years after she completed that treatment, she presents with new back pain. A PET-CT shows a solitary, intensely FDG-avid 2-centimeter periortic node at L3. The pelvis is completely clear. How do you manage this isolated nodal failure? What's your goal?
This is a potentially curable oligorrecurrent failure. We have to be aggressive. My management plan would have a few steps. First, confirmation. Always. I need to get a CT-guided biopsy of that L3 node to confirm it's metastatic squamous cell, not something else. Second, if it's confirmed, we proceed with curative intent. Given her prior pelvic radiation, the preferred local treatment is definitive stereotactic body radiation therapy, or SBRT, to that solitary node. A common dose would be something like 30 to 40 grays in 5 fractions.
And what are you worried about when planning SBRT in that location?
We need extreme caution. Highly conformal planning is mandatory. We have to rigorously monitor the OARS, specifically the spinal cord, nearby bowel, and the kidneys, and make sure those dose constraints are strictly respected. And then fourth, I'd coordinate with medical oncology to consider adding systemic therapy to address potential micrometastatic disease elsewhere.
Excellent. The shift to SBRT is the key insight there. Teaching Pearl. A single recurrence, even outside the pelvis, should be approached with curative intent. Stage 4B is not synonymous with palliation. SBRT offers the best chance of local ablation with minimal toxicity in the reirradiation setting. She does well with the SBRT. But 1 year later, surveillance imaging shows a solitary 2-centimeter lung lesion. She's otherwise asymptomatic. How do you manage this new oligometastatic lung recurrence?
We maintain our curative intent. This is a second isolated recurrence, and the principles are the same. First, confirm it. Biopsy the lung lesion to confirm it's metastatic squamous cell. Second, discuss local ablative options. The two main options for this are surgical metastasectomy, like a wedge resection, or SBRT to the lung lesion.
How do you choose between those two?
The choice depends on multidisciplinary discussion. It's about the lesion's location, the patient's lung function, and her surgical fitness. SBRT is often preferred for more peripheral lesions or if the patient is medically infirm. And finally, given this is her second oligometastatic recurrence, the multidisciplinary team really needs to strongly consider adding or resuming systemic therapy.
The recognition that you can treat this with curative intent is vital, teaching Pearl. When managing oligometastatic recurrence, our role is to provide definitive local ablative therapy, like SBRT, to eradicate the visible disease, but always in conjunction with medical oncology to control the systemic component. Let's look at a complex initial presentation, Case 7. A 55-year-old with a stage 1B2 cervical cancer primary. Staging PET CT shows the primary tumor plus a solitary FDG avid left supraclavicular node, which is confirmed by FNA, no other disease. What's the stage? And what's your aggressive curative intent approach?
Okay, the distant metastasis puts her in the highest stage, but because it's isolated, we can still aim for a cure. First, the stage is 4B, due to the non-regional lymph node, but we manage her as potentially curable oligometastatic disease. Our intent is curative. We have to target all known sites of disease simultaneously. For the local pelvis, we treat the primary with definitive pelvic chemoradiation 45 gray with concurrent weekly cisplatin, followed by a brachytherapy boost to get that EQD 2 over 85 gray.
And for the distant site.
We have to treat the supraclavicular fossa definitively. This would typically involve radiation to the left supraclavicular fossa to about 50 gray and 25 fractions, with careful planning to protect the pharynx and esophagus. And of course, we coordinate with medical oncology about potentially intensifying or extending systemic therapy.
The coordination of three distinct treatment fields, pelvis, the primary boost, and the supraclavicular node, is the challenge here. Teaching Pearl. This case reinforces that stage 4B from a single distant site is not automatically palliative. Treat the local primary definitively with chemo-RT and brachy, and treat the isolated metastasis definitively. Final case. An 80-year-old female with severe COPD and cardiac disease. She's diagnosed with a grade 2 endometrioid adenocarcinoma, clinically confined to the uterus. An MRI shows a 3-centimeter tumor invading 75% of the myometrium. She is deemed medically inoperable. What is your definitive radiation treatment plan?
Okay, when surgery is off the table, we shift from the adjuvant paradigm to the definitive paradigm for curative intent. We're going to treat her with definitive radiation therapy, which actually mirrors the approach for definitive cervical cancer. First, pelvic EBRT. This is necessary because of that deep myometrial invasion, which carries a high risk of occult nodal disease. So we treat the uterus, cervix, parametria, and pelvic nodes to 45 gray. Then we follow that with a brachytherapy boost directly to the uterus and the tumor. The goal is to bring the cumulative EQD2 to the tumor volume up to 80 to 85 gray.
Why is that target dose so high, much higher than an adjuvant VBT?
Because here we're treating macroscopic bulky disease, that 3-centimeter tumor. In adjuvant VBT, we're treating microscopic risk. Here, we need an ablative dose to sterilize the gross tumor. An 80 to 85 gray EQD2 is the dose needed for definitive cure of bulky epithelial cancers.
That distinction is key. Teaching Pearl. Medically inoperable endometrial cancer is treated definitively with pelvic EBRT plus brachytherapy, aiming for an ablative dose of 80 to 85 gray EQD2 to the uterine primary. Final challenge. During planning for that definitive treatment, the MRI shows her uterus is severely retroflexed, bringing the fundus dangerously close to the sigmoid colon. Your initial tandem and cylinder plan shows an unacceptable hotspot on the bowel. How do you modify your approach?
That's a common geometric problem. The uterus must be treated, but the sigmoid must be protected. My approach follows that same troubleshooting ladder. First, manipulation under anesthesia. I'd use a tenaculum to gently pull the cervix anteriorly, which might help antevert the uterus and pull the fundus away from the sigmoid.
And if that doesn't work,
If manipulation fails, I have to abandon the purely intercavitary approach. I would convert to a hybrid interstitial technique. This involves keeping an intrauterine component, like a tandem or cylinder, but supplementing it by placing interstitial needles into the uterine fundus and myometrium, usually via a perineal template. This combination allows us to geometrically shape the high-dose region, pulling the dose away from the sigmoid and respecting that hard bowel constraint while still covering the fundus.
that's the ultimate solution to difficult uterine anatomy. And the final teaching Pearl. A difficult uterine position, especially retroflexion, is a classic indication to escalate to a hybrid or interstitial technique. When OAR constraints are violated, you must change the source geometry. We've covered a lot of ground 8 complex scenarios. Let's summarize the essential teaching pearls. Pearl number 1. Always know your applicator hierarchy for challenging cervical anatomy ring, cylinder, and then hybrid interstitial. This is to ensure you get that adequate lateral parametrial dose.
Right. This is so critical with post-EBRT changes like stenosis. The cylinder alone will fail to cover the lateral parametrium, and the interstitial needles overcome that.
Pearl number 2. In endometrial cancer, inadequate surgical staging, so missing nodes, combined with high intermediate risk features, is a strong, non-negotiable indication to treat the nodes with pelvic EBRT.
Exactly. It overrides the PORT-EC2 data for well-staged patients. When you don't know the nodal status and the risk is high, you have to assume the risk and cover those basins.
Pearl number 3. For endometrial cancer, molecular subtype, like a POLE mutation, can powerfully outweigh traditional high-risk histology, like serous carcinoma, and dictate a significant de-escalation to observation alone.
Yes, this is really the future of GYN oncology. Prognosis is being redefined by genomics, and we have to avoid overtreating those POLE-mutated patients.
So to recap the major themes, first, definitive management of the cervix.
The emphasis there is achieving that high cumulative dose, greater than 85 gray EQD, 2 to the HRC-TV, all within a tight overall treatment time. And we have to be ready with contingencies for anatomical failure, which is the justification for interstitial.
Second, the management of endometrial risk.
Right. Accurate risk stratification is everything. HIR means VBT alone if they're staged, but escalation to EBRT if they're unstaged. And aggressive histology like UPSC means systemic therapy first.
And finally, managing advanced disease and complexity.
For stage 3C2 and stage 4B oligometastatic disease, the intent is aggressive and curative with combined modality therapy. And for medically inoperable disease, we adopt that definitive ablative dose prescription, which often requires advanced brachytherapy techniques.
That concludes our GYN case-based mock oral review. You have to know your risk groups, anchor every decision in evidence, and have those polished procedural scripts ready. Mastering adaptation is what separates competence from expertise. Great work today.
Thank you. That was invaluable boards preparation.
You can find additional practice oral boards materials at radocsmartlearn.com and subscribe to Radonc Smart Review for our next series. Thanks for tuning in.